and its distribution in different patients. It is a tortuous artery, that is a branch of the external carotid artery, and has several important branches. As it extends forward across the face, it typically gives off an inferior labial and a superior labial branch. This is usually actually a little bit more medially than is shown and is generally in the area of about 1.5 centimeters lateral to the oral commissure. In different patients, varying branches will then continue up the upper part of the face. Typically, this is described as an angular artery, which has a junction with the internal carotid system as it courses superiorly. And this can give off an inferior alar branch, a lateral nasal branch, which is the predominant blood supply to the nasal tip. From the superior labial artery, we will see a columellar and a septal branch coming forward this way. And we see in the nasal area that there is a dorsal nasal artery, an external nasal artery, which is a branch of the ethmoid artery, and then the columellar arteries coming this way. And this will be of more relevance when we are injecting the nose. We discuss these different arterial locations because when we are treating any of the anatomical structures in this region, we want to minimize the chance of intravascular injury. Thus, we will typically use a blunt cannula, either a 25 or 22 gauge, the larger bore, the less likelihood of penetration. And we are also being much more cognizant as we inject in terms of plane and depth of injection. Our landmarks for treating the mid-face are different in male and female patients, and also of patients of different ethnicities and backgrounds depending on their face shape. Typically, we want to get the most amount of elevation laterally as possible. We know if we can do what my finger is doing, this is going to improve the entire mid-face region and even lower face region. Of course, this is an exaggeration, but that is the effect we wish to create. We palpate the zygoma. That's a palpable bone as it comes across here, and we can feel the top and bottom of the zygoma. And we want to palpate for the suture line between the zygoma and the temporal bone behind it. So we look for the temporal zygomatic suture line, and we'll place a point there as our first injection point. The second point will be the malar eminence. It's the lateralmost projection point in the face, and we want to create elevation in this region. And that will be our second injection point to try and create more definition of the lateral portion of the midface. Our cheek highlight is an oval, and it's an eccentric oval with maximal diameter that occurs in the apex of the cheek. This is different in different patients, but in this young patient, this is typically the area we wish to accentuate with our injectable. This portion of the treatment is done with needle, and the lateral point is selected first. It is retracted back, and our needle is passed straight down onto periosteum. The injection is very slow in order to avoid dispersion of the product. Rather than a true volumizer, here we are using it as a tent pole or as a support pillar to elevate the lateral portion of the face. Our first injection point, we've used 0.1 cc's. We then do some slight light massage